Thank you.
Hello, everyone. Today we have a panel for you, which is part of the ongoing series of webinars from the CSF task force of the EANS. And this is actually part 2 of our series on normal pressure hydrocephalus. So I hope many of you will have seen that first session. And today we have another multidisciplinary panel. I'm Lawrence Watkins. I'm a neurosurgeon here in London at Queen Square. And we also have Giorgio Palandri, who's a neurosurgeon in Bologna, and Mats Tullberg, who's a neurologist in Gothenburg. So we have a very widespread panel who are going to talk to you from our various units about normal pressure hydrocephalus. And for those of you who are not used to the interface, I'll remind you that you can ask questions, but specifically via the Q&A panel at the bottom of your screen on Zoom. Don't put anything in chat because we'll probably miss it there. If you actually want to ask a question to the panel, put it in the Q&A section. So that being said, we're going to do in order of Giorgio first, and then my talk, and then Matt's will be last. So I'll now hand over to Giorgio for him to begin his talk.
Okay, thank you very much, Lawrence. I will start sharing my screen. Good evening, everybody, and thank you for attending this webinar. I'm really honored and excited to be here with you. The topic of this webinar deals with surgery, normal pressure hydrocephalus. Once again, thank you to our young members of CSF Task Force for this beautiful logo, and thank you to Dr. Mansour Foroughi. So, what role does surgery play in IMPH? But before trying to answer this question, let me share my point of view on why young people, for example, a student, a resident, a specialist, should be attracted by hydrocephalus. Hydrocephalus is, or I should better say, is sometimes believed to be a simple subject for simple minds and left-handed surgeons. However, to me, it has always appeared to be as a complex subject for smart guys and only for experienced teams. I would like to show you 2 personal cases. The first one is a young woman, 40 years old female, who had a VA shunt during childhood and was converted in a VPS during her adolescence. She has only slight intellectual disability. She's mother of 2 sons. She's a factory worker. And you can see that in November 2013, she underwent this CT scan. You can see the hyperostosis here, the slit ventricle syndrome, no evidence of a secondary chiari malformation. The headache resolved, but in November 2019, she was admitted to the ward in our department with headache, but this time she shows clearly the sign of malfunction and probably of the ventricular catheter with ventricular enlargement. We decided to put her on external ventricular drainage and we performed an MRI. In this MRI, you can see that there is an aqueductal stenosis, there is a minimal tonsil descent, and we decided to perform the floor of the third ventricle is bowing, and we decided to perform an ETV and possibly free the ventricular catheter through an endoscopic surgery. This is the video of the surgery. You can see that the catheter is completely obstructed and is adjacent and adherent to the posterior thalamic vein. This is the choroid plexus in its beauty, I could say. This is some sightseeing of the lateral ventricle. And you can see here that we start to free the ventricular catheter with a monopolar coagulation, careful mobilization. You can notice how adherent it is to the vein, and maybe you could easily suppose what could have happened if this was done without an endoscopic approach, simply removing the malfunctioning catheter. And here is the final stage of the procedure with a catheter completely freed. This is the control MRI, in which you can see that the tonsil descent has partially resolved. We can see a good flow through the stom of the ATV, and the patient did well till now, back to her previous life. This is the second case I want to share with you. It is only showed for you to understand how difficult it can be dealing with these complex cases. You can see here is a young man with 4 ventricular catheters inserted during many procedures, and I just don't want to go through into technical details right now. I just wanted to underline that the process from this CT scan to this CT scan required 3 months of hospitalization. I do not know exactly how many operations. It was a heavy burden indeed for the patient, for his family, but also for the physicians attending the patient and the whole nurse staff. And I personally consider the discharge at home of these patients as one of my best personal success. So we must conclude that we are like Hamlet's position. We are facing a big dilemma here, and shunt surgery must be very well weighted and discussed. In 1992, Professor Van Neste, unfortunately, I don't know him personally, but I like him from what he wrote. However, Van Neste states in this paper that IMPH is probably a very rare and still overdiagnosed disorder, and that the overall morbidity rate for each patient demonstrating meaningful improvement is high. So it was not so clear to him that the benefits outweigh the risks of operation. We could say that this dilemma resides in the balance between benefits and risks, but I couldn't say it's an easy, a simple balance. It is rather a very complex and unstable one to me. Things in the past could appear simple, starting from the clinical syndrome, the Hakim triad, the finding of ventriculomegaly, a positive TAP test was followed by shunt surgery. Unfortunately, along this path, we discovered many problems and issues to be addressed. And even shunt surgery decision implies many problems. Which kind of procedure, which valve, which catheters, which entry point should we use? And I'm very happy that after me, Lawrence will deal with mitigating problems, and Mats will tell us about the outcome. Last but not least, follow-up, in my opinion, has become an essential part of the treatment itself. It was for these reasons that in May 2015, in Bologna, we had the birth of a multidisciplinary team focusing on hydrocephalus. It is a team of professionals, of course. It is a project on hydrocephalus. It is prospective longitudinal study dealing with prognostic values on the outcome. And it is meant to be for the patient, pro-patients. So we decided to call it the ProHydro study. As I told you, it is a multidisciplinary team. There is no place for one-man show, and every colleague has a place at the table, and we strongly encourage trust and friendship. Which kind of surgery should we choose for our patient? ETV, VPS, VAS, LPS? We have many possibilities ahead. This is the choice we made here in Bologna, a VPS with a programmable valve, an anti-siphon device through a right frontal bar hole with antibiotic magnetic catheters, but it is only our choice. Please be aware that this is not the best choice. This was our choice because it is not possible to date, unfortunately, give a definite answer to this question. And we still lack studies with high level of evidence. It was for these reasons that in 2018, Dr. Jordan from Mayo Clinic published a paper, a systematic review on outcomes and complications of different surgical treatments for IMPH. And this is the flow diagram. You can see that it started from over 2,000 papers and he ended up with 33 studies, which provided data for meta-analysis. And from this table, you can see that the overall outcome is similar without statistical difference, evaluating VP, VA, LP shunt. This is the overall outcome, and this is also true if we look at gait, cognitive, and urinary impairment. Even the rate of complications does not differ significantly. As it regards ATV, we must say that the overall outcome is a little bit less favorable, accounting for 63% of the patients. Of course, we had much less subdural collections, but the revision rate was high, and due to patients who did not have a favorable outcome and then switched to the shunt procedure. In this paper, the vast majority of patients were treated with VP shunting. More than 75% of patients experienced the improvement without any significant difference among the different techniques utilized. In this paper, we could also observe that adjustable valves were associated with a reduction in revisions and reduction in subdural collections. Dealing with the VA shunt, in this paper from Johns Hopkins University, this is a paper from the group of Professor Rigamonti. They retrospectively reviewed 500 patients, and a total of 36% of VA patients and 42 of VP patients experienced at least one possible complication. And they concluded that VA shunt should be considered as an alternative primary treatment for IMPH patients. This was confirmed also by a study by McGovern, published in JNS in 2014, in which they concluded that AVS is at least as safe as VP shunting. What about LP shunting? Unfortunately, we have not much time to go into details of the surgery. I want you just know, show this paper from Professor Nakashima in Japan. In Japan, more than half of the patients in this paper were operated with LPS, and results are strictly comparable to VP shunt and VA shunt. I want to remind you that Professor Nakashima will be a guest of the Hydrocephalus Society next Saturday, and we will speak of LP shunt, and you can find more details at ishcsf.com. What about ETV? If we look at the systematic review in the Cochrane Library performed by Dr. Tudor, he published this paper in which he was able to include only one RCT with 42 participants. ETV was compared to a fixed valve procedure, which had 19% of complication, and none were observed for ATV. But since the group is small, authors could not be sure whether this was likely to reflect to a difference in complication rates, and the quality of evidence is very low. Today, we must say that there is no clear and definite evidence that ETV can be considered a primary treatment for NPH. If we go through the valve choice, this is another big dilemma. We have to say that we have at least 100 types of valves on the market, but they can be reconducted mainly to 4 types: differential pressure valves or hydrostatic valves, fixed valves, or adjustable valves. There is some evidence from the literature from the Dutch study published by Boon in JNS in 1998. They were able to conclude that the outcome was better for patients with low pressure valves than middle pressure. Unfortunately, low pressure valves had 71% of patients with subdural effusion, while middle pressure valves only 34%. How can this complication be corrected? A partial answer comes from the study published by Professor Feletti on behalf of the European IMPH Multicenter Study Group, in which they found that subdural hematoma was diagnosed in 6% of the patient and was treated by increasing the opening pressure of the valve in 5 patients that were using adjustable valves. Hygroma was diagnosed in 9% of patients, and only 1 patient required surgery. This finding is confirmed by a recent article from Mayo Clinic, in which, after reviewing their own experience with more than 300 patients, they could state that programmable valves lead to reduced rate of shunt revision. In this paper published by Dr. Sukorska in 2015, it was possible to find a clear advantage of gravitational valves compared to differential pressure valves. Patients showed a more profound improvement in clinical symptoms. Dr. Wetzel from Cologne published 2 papers on flow-regulated valves. In this one, the rate of clinical significant overdrainage was around 3%, and it is very interesting, their note in the article, that non-adjustable flow-regulated valves may represent an attractive option for patients who require frequent MRI examination and who are not sufficiently mobile, or that live far away from a hospital with a neurosurgical department in which the valve can be adjusted. In this second paper, Dr. Wetzel describes a comparable neurological improvement between DP and FR valves. And we come here to the Svazona study published in 2013 in neurosurgery, in which they compare the safety and efficacy of gravitational shunt valves versus adjustable differential pressure valves in patients with IMPH. This is a multi-center trial, and the authors concluded that implanting a gravitational rather than another type of valve will avoid 1 additional overdrainage complication in about every 3rd patient undergoing BP shunt. In this paper, where is described the study protocol, Professor Scholz and Lemke want to compare efficacy and safety of programmable versus fixed anti-siphoning device. They are still recruiting patients. They wrote me they are a little bit behind because of COVID, and we wish them good luck, and we are looking forward to their results in the future. When we look, however, finally at a systematic review, we don't have any evidence that the flow-regulated and differential pressure-regulated shunts differ with regard to clinical outcome, shunt failure, or intervention risks, and more trials are needed. What about the catheter choice? Recently, the BASICS trial was published. They enrolled over 1,600 patients. They were divided into 3 groups. one receiving a standard shunt, one antibiotic impregnated, one receiving silver shunt. The follow-up was 22 months. Infection rate was 6% in the standard, 2% in the antibiotic group, and 6% in the silver shunt group. Adverse events were comparable, and it can be concluded that antibiotic impregnated catheters significantly reduced shunt infections. Where should we place the catheter? This is a beautiful study conducted by Dr. Johnson from Minnesota, in which they retrospectively reviewed their case series, and they concluded that the catheter placed within 1 centimeter from the foramen of Monroe of the ipsilateral ventricle is significantly associated with longer revision-free survival compared with other locations. This is confirmed, in this paper by Dickerman, and in this article from Mayo. In this paper from Dr. Lind, again, they could not find any difference between frontal and parietal, but the occipital entry point was associated with a significantly higher incidence of misplacement. And the authors concluded that this may be due to the smaller range of successful trajectories. And I find this explanation extremely reasonable. I would like also to invite you to the congresses of the ANS in September and of the ANS in October in Hamburg. I'm sorry if I've been too long. I want to say thank you from all the ProHydro team here in Bologna. And let's remember that hope gives life. Thank you very much.
Thanks very much, Giorgio. We'll continue onwards with our talks now, and we're planning to do any questions at the end of the webinar. So I'm now going to share my screen, and what I'll be tackling is complications, which it overlaps, of course, with what Giorgio has already been telling us about. So here we go. So, as I mentioned at the beginning, I'm Lawrence Watkins at the National Hospital in London. And those are my conflicts of interest. Normal pressure hydrocephalus, as we covered in the first webinar, for those of you who saw it, is the triad, usually referred to as Hakim's triad. And we also talked last time about how the brain is not a static MRI, but a very dynamic structure due to blood flow through it in real life. Now, talking about mitigation of complications and improving safety, this slide shows how things have improved significantly over the years since Hakim first described the triad of normal pressure hydrocephalus. So if you look at the top table, you see the percentage of improved patients at 3 months was around 45%. So not a massively good outcome. And that has gradually improved over the decades, so that now if you look at just the last 25 years, since 2006, or the last 15 years since 2006, we see that now the reported improvements are around the 80% plus range. So there's been a very definite trend towards improvement in outcome. And then looking at the lower table on that slide, this is from a systematic review, the mortality rate in the 1970s was 9.5%. So if you think about it, if you were a neurosurgeon in the 1970s looking at a 45% success rate and a 9.5% mortality, never mind complication rate, it wouldn't be that attractive proposition to try and get referrals for this condition. But now over the years, again, looking at the last 15 years, instead of historical data, Mortality rate reported in the literature is around 0.2%. So now we're having a massively increased success rate and a dramatically reduced complication rate. So now that's why in the last decade particularly, this has become a very eminently treatable condition. So how do you reduce complications? When any surgeon will tell you the best way to not have a surgical complication is if you don't operate at all. And so in practical terms, what that means is always remember that there is conservative management for many conditions. Normal pressure hydrocephalus, though, once you've made the decision, there aren't really many options. And in fact, there is good evidence, as we saw in the last webinar, that the longer you leave people with untreated normal pressure hydrocephalus, the worse their outcome is. They don't always recover what has been lost through delay. But when you're treating any patient, you should at least consider that and discuss it with the patient, gather all relevant information, and particularly important with NPH, select your patients carefully using the best predictive tests that you have available in whichever unit you're working in. Operating early in the natural history also has a better outcome, specifically talking about normal pressure hydrocephalus. And so our tendency as surgeons is, once the decision is made, to not delay unnecessarily in treating the patient. And this is just to remind you of the slide that we saw in our last talk. Kirsten Andren in Gothenburg looked at cohorts of patients. The green cohort is people who were operated on fairly soon after their diagnosis. And you can see the pre-op to post-op, the significant improvement in their NPH score. But there was another cohort that was delayed for more than 6 months. So if you look at the red bars, they were comparable at the beginning of the study, but by 6 months later, they had deteriorated further. And more importantly, they never regained as well as the cohort that had been operated on soon. So the other way to reduce complications and improve outcome is to operate early. The other thing, strangely enough, is that older patients seem to have less complications from shunting, which is kind of counterintuitive. Most people assume that operating on older people is going to have more complications, but all the data shows that is untrue. They have fewer complications. And the other thing, as Giorgio has already mentioned, the use of programmable valves seems to have a definite advantage in this condition and this age group. Now, looking at this slide, which is from the UK Shunt Registry, and this is following a cohort. The Shunt Registry has very large numbers of patients in it. And so this particular cohort is looking at over 40,000 operations and looking at their revision rates using programmable or not programmable, that is fixed pressure or adjustable valves, and segmented by the age of the patient. And then this is the cumulative revision rate over time. So it's 312 weeks at 6 years. And so the over 70s have the lowest cumulative revision rate. And you can see the difference between the fixed pressure and adjustable valve is the greatest in that age group. Pediatrics has the greatest revision rate and not a very large difference between fixed pressure and adjustable valves. The other thing, as Giorgio mentioned from the papers that he cited, is to use an anti-siphon or anti-gravity component, which reduces complications, in particular the formation of subdurals. So in the Spasona trial, for example, comparing shunts with a gravitational switch to stop over drainage, there were 29 patients in the standard shunt group without such a component and only 5 in the gravitational shunt group. So that was a significant and matched up in other studies. The other thing is, if you possibly can, seems obvious, operate only once. In the UK, we have a nationwide audit, which is called GIRFT, getting it right first time, trying to reduce the rate of return to theatre, reoperation over time. And if you look at shunts, for example, this is again from the very large UK shunt registry, the difference between primary and revision shunts is very great. So if you're having your first ever shunt as an adult, your revision rate over 6 years is about 20%. It's more than double that if it is a revision or subsequent revision. The message of that should be to try to operate as only once if possible, and try and get that first operation correct. So any of the techniques that we're talking about, selecting the right valve, the right anti-siphon device for the patient, that's when you should expend the most effort to try and make that first shunt perfect and let it last for a long time. And that will be doing a lot of good for each individual patient. The other aspect to reduce infection rate is the use of antibiotic impregnated shunt tubing. So the BASICS trial, looking a bit more detail into what Giorgio has already mentioned. This was a large multi-center randomized controlled trial with 3 arms between standard non-impregnated tubing, antibiotic impregnated tubing, and silver-coated tubing. And the headline number of revisions, the percentage of revisions for infection in this group are highlighted, about 6% in the standard and silver, but only 2% in the antibiotic impregnated shunts. And with large numbers, that is a highly significant result, and I think has already been practice changing in many units. The other thing which has been accumulated from research over decades now is that most of the organisms that we encounter in shunts are very low virulence organisms, such as Staphylococcus epidermidis and the Cutibacteria, which live on everyone's skin anyway. So, and the studies done at the Institute of Child Health suggest that the majority of the infections that colonize the inner lumen of shunts come from the patient's own skin microbiome. The other things to know is that skin prep sterilizes the surface, but deep pores of the skin remain colonized with these low-grade organisms. And so as you cut through skin, you actually expose the deep pores along the edges of the wound. And this can be a source of bacteria getting into the wound and therefore into the hardware at the time of operation. And so such practices as using betadine or other compatible antiseptics to clean the skin edges after incision, and any instruments that have come into contact with these skin edges also seems to reduce the infection rate from the patient's own skin. And so this is a published technique of using skin preparation, applying the Ioban or some similar plastic drape to reduce contamination from the skin, and using povidone iodine on the wound edges to reduce contamination of the wound from the patient's skin. The other thing that we touched on there was the landmarks for placement of the ventricular catheter, and particularly in the occipital region, it can be difficult. And there, as Giorgio mentioned, fewer trajectories which successfully hit the ventricle when you're going from an occipital rather than a frontal burr hole. So just to give one technique of how you target from an occipital burr hole. This is Michael Jackson's hat. And if you try and remember the position of his hat band, that is the slice of the CT that we're interested in. So it's from the lambda, the top of the occipital bone, to just above the brow ridge. On an X-ray or a tomogram, as you can see here, that is the slice that you would get. And that slice on a CT scan looks like this. So you can see the ventricles are on that slice of the CT scan. And if you look at the markers at the external auditory meatus, which is the one on the lateral, and the external occipital protuberance, if you take that at 0 degrees and 90 degrees, you go halfway in between them on the on that slice, on the hat band equator. And then you are planning a trajectory which passes through the center of the oval of the head as seen from above. So that central cross is where we're aiming our trajectory through. When we reach the middle cross, i.e. the tip of the ventricular catheter is in CSF, you then hold the stilette, which is stiffening the catheter, steady, and advance the soft silicon catheter off that metal. And so then it can't damage anything beyond that point. You're in CSF and it will just follow the contours of the lateral ventricle. And for an adult, in most cases, 9 or 9.5 centimeters will get to that magic point. As we mentioned, there are studies showing that if you aim for within 1 centimeter of the foramen Monro, it seems to have the lowest complication rate. And so that is a technique of doing it. Obviously, if there's any distortion of the anatomy, or if the ventricles are small, you should use image guidance technology to place the catheter. But that is a way of targeting it freehand. So what blocks the ventricular catheter? The very first case that Giorgio showed us, you could almost see the glia crawling across the CSF space and into the holes of the catheter. And Carolyn Harris in Detroit has shown by doing electromicrographic studies of blocked catheters that have been taken out of patients, that mainly the blockage is due to glial migration into the lumen and also macrophages. The catheters can get stuck to choroid plexus, but that seems to be less common. That is the neurosurgical myth, is that it's always the choroid plexus invading. It isn't, in fact. It can get stuck to it, but the majority of cases, it's glial and macrophage invasion of the lumen that causes the blockage. And the implication of that is that all the holes of the catheter should be in CSF. If you have even one hole within parenchyma, then those glial cells are going to follow the contours into the catheter and soon block it. Whereas if all of the holes are out in CSF and free of the parenchyma, then you won't get that invasion problem to the same extent. The best location is the frontal horn. That's shown on several of the studies already mentioned. But as long as you actually hit the ventricles and get the tip into the frontal horn of the lateral ventricle, near to the foramen Monro, the actual burr hole position doesn't matter as long as you're successful. It only matters insofar as if you're not successful, then it is more difficult from an occipital burr hole. Another complication which neurosurgeons try to avoid is the migrated catheter that's come out of the peritoneal cavity. And you can see it coiled up in the fat of the subcutaneous tissue outside the peritoneum. So in most cases, we can see on post-operative x-rays that it has been in the peritoneum. So this does seem to be a migration issue. And the ways to reduce that is to tunnel the catheter deep in the fat. So not close to the skin, but deep down in the fat so that it's closer to the fascia. And the theory behind that, Dr. Nagasaka has put forward the theory of fat pad movement being the mechanical stress that pulls the catheter out of the peritoneum. So when the patient stands up, particularly if they have a lot of subcutaneous fat, that fat moves relative to the abdominal wall and pulls the catheter out a bit. And because it's passing through a very small hole, once you pull out a centimeter or two, it doesn't necessarily return into the peritoneum. And so with the standing up and sitting down, lying down, and this time he sits up, a bit more comes out, and eventually all of the peritoneal catheter ends up coiled in the fat. So if you tunnel the catheter very close to the fascia, then the fat pad is less likely to pull the tubing out with movement. In a broader sense, how do you reduce complications? Well, the first is to have a protocol. And the Adult Hydrocephalus Research Network in North America has shown that protocols do reduce complications. Deviations from protocols seem to increase complications. But the interesting fact is that the protocol in their centers varies. And yet having a protocol seems to be much superior to not having a protocol. So have a protocol and stick to it in your unit is much better than not having one and just letting everything be ad hoc. Protocols do evolve, but there is a benefit to routine. And so if possible, keep the same shunt tunnelers, keep the same valve systems that you're used to and familiar with, and keeping the same team if you possibly can. The less variables from time to time, the more likely you are to have a successful routine. The other thing to bear in mind is that the hidden benefit of complication rate being low is that it increases the pool of our potential patients. And just to return to that first slide I showed you, by reducing the complication rate, in this case mortality, just to pick that out, from 9.5 to 0.2, while increasing the successful outcomes from 45 to 81, obviously our pool of patients that we're prepared to operate on dramatically improves. So reducing complications is not only just good for the individual patient, but means that you open up the field to more patients to benefit. So the philosophy of hydrocephalus management is not that dealing with a single clinical event where we deal with a problem, say goodbye to the patient, and hope they never come back. This is a long-term condition, more akin to something like diabetes, which is ongoing. And we are managing that long-term condition to reduce the number of interventions and reduce that patient's overall complication rate over a lifetime, not just from the individual operation. And by minimizing the cumulative complications that they get over the course of their life, you dramatically improve quality of life over time. So I'd like to thank you for your attention, and of course all of my great team here at Queen Square. And I would mention that this series of webinars is brought to you by the EANS CSF Task Force, which you can follow on Twitter. And I'd encourage you, if you're interested in this sort of thing, CSF management, please join the EANS Task Force, which is trying to develop this as a subspecialty within neurosurgery and neurology. Thanks very much.
Thank you very much, Lawrence. Excellent presentation. And I think that we could go ahead with Mats.
Okay.
Here I am, just getting my camera on. Hello, everyone. I'm also very happy to be here and talk to you today. I will move to my talk here in a few seconds. I'm a neurologist from Sweden, Gothenburg, working in the Hydrocephalus Research Center unit at Sahlgrenska University Hospital. And as a neurologist, I see patients every week coming in for clinical workup, for diagnosis, and seeing patients coming back for the post-operative control. And I think, as has been mentioned here, it's very important to do a real thorough clinical assessment, both before for diagnosis and after treatment, because this is the clue in treating the patients well. If you don't have a good record of tests or assessments to compare with when the patient comes back, you cannot really evaluate the effect of treatment. So I will start by showing you just one example of a patient who was treated in our center about a year and a half ago. You can see how she walks preoperatively to the left here. She had gait and balance difficulties since the past 2 years when she came to us. She used a walker, but even so, she fell over and over, and she almost never left her house. She was very clumsy, and she had an increased need of sleep. She also used diapers because of urinary incontinence. Moreover, she was forgetful. She was apathetic, and she had an increased need of sleep. So she was diagnosed with INPH and shunt operated, and came back to us about 4 months post-surgery. And you can see here how her walk has improved dramatically. She's still a little bit careful when walking, but she now manages much better. You can also see that she has dressed a little differently. She told us she had never fallen once since the operation. She had stopped the home care service, and she managed her own needs totally. Her memory ability and her ability to concentrate improved much, so now she was able to read books, which she wasn't before. Moreover, she didn't need the 2-hour daily naps anymore. And she also told us that before coming to the hospital, she had adjusted the length of her trousers manually, which she would never have been able to do before. So this illustrates a really favorable outcome, which is of course what we like to see in every patient. That is unfortunately not the case. But I would like to show you some data and reports telling us a little bit more about the outcome. And I will focus on 3 parts. First, the short-term outcome. I will then later talk a little bit about the long-term outcome, which is also important. And in the first 2 parts, I will focus on clinical symptoms. The third part will just briefly mention quality of life, which is not unimportant at all, really. So the short story of short-term outcome, I think, must be defined as a very successful story. I will show you 2 studies first to illustrate this, 2 quite recent studies. The first one is the Symphony study from Japan, published in 2010, including 100 patients with INPH. And if looking at the outcome at least 1 point over the first year, 80 of the 100 patients were improved in this study. But looking at the outcome after 1 year, you see here that 77% improved on the INPH gait scale, while 69% improved in the modified ranking scale, but by at least 1 point. The MRS is a much more crude measure. You can see the distribution of changes to the right here, showing the 69% improvement. In the European multi-center study published in 2012, the selection of patients was based on clinical symptoms and MRI alone. And here, as the INPH scale published in 2012 was used for assessment of outcome. This scale includes 4 domains: gait, balance, continence, and neuropsychology. You see these 2 figures at the bottom. This illustrates what can be seen in a patient pre and post-operatively if you see an improvement. The scale reaches 100 points, which is equal to a normal values for healthy controls of the same age. So in this study, 84% improved in the overall INPH scale after 1 year. And looking at the different domains, we can see that 77% of patients improved in the gait domain, 56% in the balance domain, 63% in the neuropsych domain, and 66% in the continence domain. And in this scale, gait is a little bit heavier weight than the other 3 domains. Considering the MRS, there was also the same result here, a 69% improvement. Just to mention that everything is not just gait and balance, neuropsych and urinary incontinence. This patient I showed you had an increased need of sleep and had to take daily naps. We published a study in 2004 looking especially at impaired wakefulness, and in the normal pressure hydrocephalus in a small material with also secondary cases, but the majority were idiopathic. If you see this symptom, in my experience, it's very typical, and it responds very well to shunting. In this study, we assessed the level of wakefulness using a scale called the somnolence sopor coma disorder scale, a 7 level scale. I will not go into more detail here, but 1 or 2 score of 1 or 2 represents normal wakefulness, whereas higher values represents impaired wakefulness. And if you look at the picture to the right here, 16 out of the total 28 patients showed signs of impaired wakefulness, and in 14 of the 16 patients, this impairment disappeared or vanished. So there is a very good effect on this symptom also, and there are other symptoms that I will not have time to go more in detail here about. Lawrence, you mentioned this very nice and elegant review, which I think is telling us a lot. So I will not spend much more time on this, but again, just say that over the years, the improvement rates have improved, and the last part between 2006 and 2010, we have short-term improvement of up to 1 year of around 80% or slightly above, which is really very good for a surgical treatment. Now, if we look a little bit to the long term, because it's important to consider what happens after the first revisit for 3, 4, 6 months or a year. Are these results lasting? And my answer is to this question is yes, mainly. This is a Japanese study published in 2019. We look at the right figures to the right, where we have the post-operative outcome after 4 years. They've stratified for 2 age groups, up to 80 years or above 80 years. We see that 82% of the patients younger than 80 years were still improved after 4 years. And in this study, they used the Japanese INPH grading scale. And for the older age group, 71% or 70.7% were improved, which is really a good result. We published a paper using an inquiry that was sent out. This was based on our data from our Swedish quality registry. So we were able to include a number of patients, sending them letters asking them how are you feeling now compared with your condition before surgery, and we could reach a number of patients up to 6 years after the primary surgery. And the main result here was that around 60% were improved over this, or considered them improved during this period. So even if we are dealing with older patients, and of course age plays a role here over the years coming, patients still, in the majority of patients, still feel better after surgery. They can also, of course, be subjected to other conditions too. And these results were not influenced by either vascular comorbidity or reoperations due to complications. And not least, the last result here is important, I think. So even if patients suffer from complications, in the long run, at least according to this study, they seem to feel fine, as well as patients who do not suffer from complications. And again, this study showing the long-term outcome of lately of up to 70% or slightly above, which is really good. So finally, a little bit about health-related quality of life. I will just show you two studies here. One is from our center, published in 2014. Here we looked at health-related quality of life using this EQ5D, 5-dimension questionnaire with 3 levels, assessing mobility, self-care, usual activities, pain, discomfort, and anxiety or depression. In this questionnaire, there is also a visual analog scale, as you can see to the right here. This is one of the instruments that is commonly used for assessing health-related quality of life in different disorders or in health. So what we found in this group of 37 patients checking health-related quality of life before surgery and then 3 months after surgery, 6 months after surgery, and also comparing to levels in the normal population. And looking at the VAS scale, which is a little bit easier to comprehend, you can see that looking at different age groups, the results were between 50 and 66 on the VAS scale before surgery. After surgery, improving, as you can see, significantly. And compared to the normal population, they didn't quite reach the same levels, but they were almost there really. And as you can see, a higher proportion of patients in this material reported improvement in health-related quality of life than in overall symptoms. And also when we measured improvement by our standardized clinical assessment, the improvement rates were slightly lower than the health-related quality of life. A more recent study looked at this post-operatively. It was also based on the health quality registry, Hydrocephalus quality registry, showing that health-related quality of life improved after surgery, as you can see in the first 2 parts here, and compared to controls, there was a significantly lower health-related quality of life still after surgery. The conclusion here is that there is an improvement here, but patients do not reach the same level as the normal population. And this is probably something that we can look more deeply into. In this study, symptoms of depression and also severity of gait disturbance were the strongest predictors of low quality of life in INPH. So to end up here, my take-home messages are: shunt surgery is a very effective treatment in idiopathic NPH, also in a longer time perspective. Patients are improved in clinical symptoms, but they are also improved in health-related quality of life. Thank you very much. And I also want to thank the organizers here. I'm very happy to be a part of the CSF task force, and I hope that that will evolve into something very important. I invite you to the Hydrocephalus 2021 virtual meeting. And also, if you want to come visit us here in Gothenburg next year, in September 2022, we will have the next physical congress. We really hope. Thank you very much.
Thanks very much, Mats. That was excellent. And we've got a few questions to interest us. One from Dimitris was asking about adjusting the adjustable valve post-operatively. And there are, of course, various ways of approaching this. Some neurosurgeons start off at a very high pressure and move downwards. And I've heard that said as one approach. You start off at whatever is the maximum valve pressure, progressively reduce it. And then when the patient says that seems better and their walking is improved, then you don't go any further than that. That's one option. The other option is to start off at a pressure you think will do the most good. And this varies because it depends on the characteristics of the valve that you're using. If you have a valve that you're very confident in its anti-siphon devices, then using a lower pressure on is not going to have such a high risk of subdurals. Whereas if you're using one where the anti-siphoning properties of the valve are not that great, then you have to be much more cautious in reducing the opening pressure of the valve. So for example, if I'm using a Mithka with an adjustable component and also a gravitational switch, then we might start off at 5 centimeters of water, which is a low pressure, but a pressure which is probably physiological for this age group, so that they immediately begin to benefit from their shunt rather than having to wait until you finally get down to the level that's going to do them some help. But if I was using one without a gravitational switch, I would be much more cautious and start off at a high pressure. And that is, in fact, what we used to do in the early days when the very early adjustable valves were available. So there isn't a set answer, I think, in my view, but it depends on your knowledge and confidence in the valve you're using. What do you think, Giorgio? You're a neurosurgeon. What do you do?
I do agree with you. I always kept in mind the Dutch study in which the outcomes were much better with the low pressure valves.
Yes.
So we use an adjustable valve with an anti-siphoning device in every case of IMPH we treat. And we try to start as middle pressure valves in order to avoid early complications. For example, subdural, unexpected subdurals. We perform a scan in 1 month in every case, and then we just aim at lowering the valve till 6 or 8 centimeters of water.
I think you are describing this problem very well. We use about the same management as you described. We have not used gravitational valves a lot, but we use a standardized setting, and then we consider reducing it carefully, at least one step, if we don't see the improvement that we have expected, or if we still see NPH symptoms. And I think you should do a routine CT scan every time you reduce the valve, because sometimes you get surprises. Even patients without symptoms can show considerable signs of subdurals. There is a very low scientific evidence, though, of reducing, having a protocol of reducing shunts, valves, sorry, and having improvements. So I think we need better knowledge here, really. I would like to have better evidence on comparison of gravitational and differential pressure valves.
Yes, and on a similar note, Zofia Czosnica in Cambridge points out that postural overdrainage can't be completely rectified simply with an adjustable component. You have to have some gravitational switch or siphon control device, because otherwise, if you turn an adjustable valve without an anti-siphon control up to stop siphoning, then you're going to stop it doing as much good for the patient. I think the clinical evidence, Giorgio mentioned the Dutch study, is that lower opening pressures do more good for the patient. And so what you want to do in an ideal world is to start off at the setting that's going to actually have benefit for the patient. Because if you work down slowly over many months, then all of those months are essentially wasted when the patient is not getting the benefit of their shunt. On a similar note, Zofia also is asking about shunt testing in patients once they have their shunt in. If they come back a year later and we're concerned about their deterioration or the fact they haven't improved, how do you test it? If you, as you were saying, that if you use in vivo testing, it could be either infusion studies or shuntograms or intracranial pressure monitoring. These are all in vivo study techniques. You can reduce the revision rate. So whereas if every time somebody turns up with a problem, you revise their shunt, you may be putting them through unnecessary risk. So certainly I would agree with Zofia on that you want to not immediately rush into revising shunts without investigating, depending on what resources you have in your unit, through one of these techniques to work out who actually needs a shunt revision. What does the rest of the panel think about that point?
I completely agree.
Yeah, unnecessary revisions just increases your complication.
No, you should really be sure of the situation before putting the knife or the patient on the table, I think. And we usually do shuntograms first and then LD lumbar drainage test to really test the shunt if necessary.
I do completely agree with you. I think this is a very good point. We must avoid unnecessarily revising shunts. I must say that honestly, we don't do in vivo testing except for a withdrawal from the valve of CSF, and that is an indirect test. But we should implement it in the future, and I think that Marek has really a very good point in it.
Leading on from mention of lumbar drainage and tap tests, another question is what sort of preoperative testing do you routinely use? Because there's a huge selection: lumbar puncture, repeated lumbar punctures, extended lumbar drainage protocol, or in some centers, ICP monitoring with pulsatility analysis. From my viewpoint, we use the extended lumbar drainage protocol very much Marmaru style. Marmaru described that many years ago. And because that is most closely mimicking the work that a shunt will do. And I would point out that this is the difference between a diagnostic test, which may be looking for an indirect measure to make the diagnosis, and a prognostic test, which is actually testing the response to CSF drainage. So an extended lumbar drain has a very good positive and negative predictive value for what the patient will be like once they've had their shunt put in. So that's the one that I favor, but it is very resource intensive, requires a few days in hospital, and so not available in all units.
I must remember you all that there is a risk of excluding patients with negative prognostic tests today. So there is a need for better tests. In our center, we mainly diagnose and treat patients based on clinical symptoms and MRI, and then we add mostly the CSF tap test or lumbar infusion test, I mean, if we are unsure. But that has worked well, but that requires a very thorough clinical assessment so that you really see if you can recognize the symptoms.
That's our attitude, even here in Bologna.
Yeah, I think you make a good point, Mats, though. Almost more important than making the diagnosis is not denying the benefit to somebody who would have had a good outcome. And so you simply doing a lumbar puncture of a small volume and then saying, well, they didn't improve, sufficiently, therefore I'm not going to do a shunt, is going to exclude a large number of patients who would have benefited. So that on its own is not enough to make the decision.
There is a question about if we prefer programmable valves.
Yeah.
Can't we state that that is the state of art today?
Yes.
Yeah, there is no place for
no, we presented the data there, and certainly from the UK shunt registry, those multicolored curves that I showed you of revision rates, the evidence on large numbers of patients is that particularly in normal pressure hydrocephalus and particularly in the elderly, programmable valves have a benefit. And so I think that point is made. If you have them available in your unit, you should be definitely preferring them for this patient group.
Yes, this is true. Comparing adjustable valves with fixed valves. Of course, we have to keep in mind that another option could be the flow regulated valve.
Yeah, that's right. And there's a question which I think Mats, as our neurologist on the panel, should be able to. There's a question: do patients with INPH have REM sleep behavior disorder?
Good. I was thinking about that one. Thank you. It's a very interesting question. The fact is that I don't think it has been studied thoroughly. In my experience, if you see a patient with REM sleep behavior disorder, you should suspect a typical Parkinsonian disorder or a similar disorder. So another neurodegenerative disorder. But there might be cases with INPH or NPH that has it. I haven't studied it, but it's an interesting question. So far, I think you should really look for other causes of disease if you turn into a patient with that. I don't know if you have any comments, my colleagues here.
I was Googling it.
Are you allowed to do that?
If we didn't have a neurologist on the panel.
Thank you. There might be a case report, but then it could be a coexisting other disorder. So if it's a pure NPH sign, I wouldn't be sure.
No, I think that's true. It's not well enough evidence-based for us to be definitive about that. And another question is there any comment on lumbar peritoneal shunts? I know Giorgio mentioned that certainly in Japan there is a high incidence of using LP shunts, but it's much less common in Europe. My own view on that is there are adjustable lumbar peritoneal shunts available, and in the small number that we've done in our unit, the results are pretty good. But you would expect, since they don't have anti-siphon devices in them, that they might be susceptible to a higher rate of subdurals. But that having been said, the Japanese who are used to doing this as a treatment report very similar outcomes from either lumbar peritoneal or ventricular peritoneal shunt. So I think that comes back to my point of use what you know and what you're familiar with and can show that you achieve a low complication rate. Either is feasible.
Yes, I do agree with you. The question is very interesting because, of course, LP valves avoid the cerebral shunting, and so I think they're very interesting. But you mentioned in your talk, Lawrence, that routine must guide us in avoiding complication, and I think that we must keep in mind that shifting from VP or VA shunt to LP shunting is not really very easy. Even complications might be really difficult to afford at the very beginning of our experience. For example, here in Bologna, we use LP shunting for IIH. Of course, there are much fewer cases here. and we didn't take into account really a complete shift to LP shunting. I think that it is very interesting, the concept of atrial shunting, because in some ways it is really minimally invasive, and it has been demonstrated on by the papers I showed you that you don't have so many complications as we feared in the past. And for example, right now we are dealing with obese patients, older patients who afford badly the peritoneal catheter. And so I think that the AV shunting more than LP shunting could be an alternative.
We are overrunning our time, but if there are any other questions that other panelists have picked up and would like to take on, this would be an opportunity. We can overrun a bit.
Mass overlapping between IMPH and Parkinson. Very interesting question. Yes. I think that we would need an entire webinar on this.
I agree. It's a very important question, and when doing workup, I focus very much on excluding Parkinsonian disorders. I think that's more difficult than the dementia spectrum disorders, not least atypical Parkinsonian disorders, the progressive supranuclear palsy, for instance. So there is a considerable number of patients with both disorders. There is a group which do not have NPH or INPH, but rather a Parkinsonian disorder. But there are also cases where the two disorders are coexisting. And I think it's a subject for a separate webinar. But it's very important. So you highlight an important thing there. Thank you.
Certainly in here in the National Hospital in Queen's Square, I find that most of our in-house referrals of normal pressure hydrocephalus come from the movement disorder group. In people who have been referred, is this a Parkinson's disease? They think it isn't Parkinson's disease. And then the next most likely is that it's an NPH patient that's been referred into them.
Yeah. I agree. I think that we have about the same way of getting patients. And it illustrates the importance of cooperating with the movement disorder team. Absolutely. If you get a referral from that team, you can feel pretty sure about the component of the other disorder, or if it's not there. But you must remember that that diagnosis is also difficult. It's a clinical diagnosis. You have to follow patients over time. Sometimes you need to see the effects of treatment. So even if the movement disorder neurologist says this is probably not Parkinsonian disorders, the situation can be different a year later.
Do you routinely use DAT scan or response to levodopa, for example?
Good question. We try to use DAT scan when we really need it, but not in clinical routine. We do it in selected cases. If we find any evidence of extrapyramidal symptoms, we try to treat with levodopa for a period of time up to 3 months, usually. Mostly to see what the component of Parkinson's disorder, not the atypical cases, but that is indicated, I think.
Very good. If my panel agrees, I think we should probably wrap it up there for this webinar. And like every research paper finishes with more research is needed, I think our conclusion is always, and now we need another webinar to answer all this.
Very good.
So thank you to everybody for participating. Thanks to the panel. Thanks to our audience. And yes, look out for more webinars in this series. there's just so much to learn, and it's all a fascinating subject related to CSF. Okay, thanks everyone.
Thanks everyone.
Thank you.
Thank you.
Thank you very much.
Thank
Bye.
you,